The broadcast is now starting. All attendees are in listen-only mode.
Well, good evening, everybody, and welcome to another special edition of the RX Question Lab. Tonight, we are going to be diving into the gastrointestinal system with questions that are focused on the types of items you'll be seeing on step one. My name is Jeff Downing, and I'm going to be guiding us through tonight's set of questions and dissections. And lucky for me and lucky for you, we're fortunate to have Dr. Abraham Titus with us tonight as our in-house expert. So, Abraham, would you like to say a few words to introduce yourself?
Sure. Thank you, Jeff. So my name is Abraham. I'm one of the hematology oncology fellows at the University of South Alabama. I've been a tutor with Scholar RX for quite a few years now. I've had the pleasure of working with many students and helping them achieve great things on step one, step two, and even step three. So let's get cracking and do some GI today.
That sounds great. And we also have Kate, who is here with us tonight, and she is going to be answering questions in the question box. So if you have questions, inquiries, clarifications, comments, suggestions, head on down to the question box, and we will do our best to answer your questions. Question Lab, we're going to have well over 100 folks here tonight, so if we don't get to your question, don't take it personally. We are going to do our best. So we're going to go ahead and get started. Okay. So the one thing I want to stress here is that here at Scholar RX and USMLE-Rx, we're really very focused on trying to create tools and services that will support you at every step of your journey. And we've been doing Question Lab for over 4 years now, and our goal here is to help you as you develop your methodology for answering questions. So again, as we go through this, we are going to kind of focus on technique and really get you to think about the ways in which you can attack these questions. So again, hopefully you're going to learn something, and Abraham is definitely going to be here to help explain some of the trickier concepts. But we do want you to be thinking about your approach to answering these questions, so that on test day, and it's not just USMLE test day, but you might have self-assessments coming up. You might have a CBSE that you'll know how to perform at your best. Okay, so what we're going to do is we're going to start with question one, and when I open up question one, something is going to stand out. Now you might look at it and say, "Oh, looks like we've got a CT scan," but the one thing that's missing here is the answer choices. And this is by design. We really want you to, take on every part of the question in a stepwise manner. And in order to do that, we encourage you to just cover up those answer choices first. And we, we advise you to do that because there may be an answer choice or answer choices that are things you've struggled with, or things you don't know. That's completely within within the realm here. So what we want you to do is just focus first on the lead-in. Okay, you cover up the answer choices, and then part two is you look at the lead-in, and that is the question part of the question. So in this case, your lead-in is, which of the following would most likely be lower than the normal reference range in this patient? Okay, so you've got the answer choices covered up, and then you read that lead-in first, because now you can look at the vignette with an eye towards, okay, I know what type, I kind of know what I'm looking for, or at least I know what I should be thinking about as I'm absorbing this information. If you read the vignette first, you're taking in a lot of info, but you're not exactly sure, what parts of the scenario are going to be relevant for you, or how they apply to the question. So we say read that lead in first, and then once you've got that, now you can read the vignette. So that's what we're going to do right now. A 35-year-old woman comes to the physician because of intermittent jaundice and upper abdominal pain for the past 10 years. She does not see a physician regularly. Her temperature is 38, pulse is 88, respirations are 18, and blood pressure is 110/74. Physical examination is remarkable for scleral icterus and an abdominal fluid wave. CT of her abdomen is shown. So once again, which of the following would most likely be lower than the normal reference range in this patient? So you think about that, head on down to the question box and let us know how many steps you think it's going to take to answer this one as I turn it over to Abraham.
All right, thank you, Jeff. So he made some great points about first reading the lead-in and getting an idea of what the question is going to want. Thinking of what that happens, and then attacking the vignette. Now, this question, the vignette's not too bad, but some questions you'll run into are gonna have huge, massive vignettes. You gotta have a systematic approach to answering these questions. You don't wanna zone out in the middle of reading it and forget what you read. So why don't we go through, why don't we highlight some keywords from this question, and then let's try to figure out what's going on here. All right, so again, the lead in first, right? Which of the following is lower than the normal reference range? It's not asking about diagnosis, not asking anything like that. It wants you to know what's lower than normal. Go to the question. I always like to think a 35-year-old woman, so it's a demographic, know generally who I'm dealing with. Intermittent jaundice and upper abdominal pain for 10 years, duration and symptoms. Fever 100.4, so right on the cusp there. And vitals otherwise okay, but has scleral icterus and abdominal fluid wave. So what does abdominal fluid wave mean? And then I look at the CT. Okay. Now this is step one, right? So we're not expected to be radiologists and know exactly what we're looking at every time we look at a CT. But if with the question that primes you to already have thought of something, you want to use the CT to support your diagnosis. Even if I don't know anything I'm looking at, you can still get the answer without the CT. But the CT is kind of a confirmatory extra step that's there for you to refer to and use that. So after you guys think about what's going on, we're going to think about how many steps this is going to take us to get to the question. And then we're going to finally think of an answer in our head. Then we're going to look at the options. So let's reveal the options. All right, so typical classic 5 options. I always like to think, let's start with E and make our way to A, right? So we don't get biased by the first thing we see. So option E, prothrombin time. Option D, platelet count. Option C, partial thromboplastin time. Option B, bilirubin. Option A, alkaline phosphatase. Again, which of the following is lower than the normal reference range in this patient? Think about the diagnosis, think about what's going on, and think about the labs that this patient would have in their diagnosis, and what would be lower for them. And if you can think about why, you can drop that in the question bank after, but the question is just asking you, what's lower than normal? Take your time, think about it, and a poll will pop up shortly.
Okay, everybody, we have launched the poll. We're in it. So go ahead and take your best shot. Out of all of these values, what do you think will most likely be lower than the normal reference range for this 35-year-old woman? And I'm going to share the results. So looks like about 40% of you went with platelet count, and the rest of the votes kind of split. Prothrombin time coming in second, and then PTT and alkaline phosphatase coming after that. So decent spread. So let's go ahead and we're going to hide the results, and let's share answer. And the answer is platelet count. So everyone who got that, congrats. Good way to start off tonight's session. If you didn't get it right, that's all right. This is all about improving. So Abraham's going to walk us through the explanation.
All right, great job, guys. So again, this is a very classic question, but all of it comes down to, can I diagnose this patient? So 35-year-old woman, okay, not too much there, but the intermittent jaundice and abdominal pain. So that should be kind of ringing bells. Or when I'm thinking jaundice, what's going on? My bilirubin is going up and causing me to have this yellow skin that's appearing. Now, this can happen secondary to my liver or my biliary tract not working, or secondary to hemolysis. But with that upper abdominal pain, and with them giving you the story of the abdominal fluid wave. So what is that abdominal fluid wave they're referring to? That is ascites, right? So whenever there's fluid wave shifting going on in the abdomen, that's what they're referring to. So patients with jaundice, ascites, can have a low-grade fever. And then if I look at the actual CT, I don't have to be the greatest at looking at CT, but it looks kind of weird, right? I have to always orient myself, which is my right, which is my left. So when I look at a CT scan, I'm looking at a patient's feet looking upwards. So the left side of the CT is actually the right side of the patient, and the right side of the CT is the left side of the patient. So if I look at this, that gray blob that's on the patient's left side is actually the patient's spleen, and the right blob is the liver. So here the spleen looks huge in comparison to the liver. So that's something that you learn to get better at as you kind of go through this. But the patient has a cirrhotic liver with splenomegaly. That is classic for a cirrhosis. So they want you to understand that this patient is having classic symptoms of cirrhosis. They could have given you all of the other features, right? Some of the other features like my poor wound healing, you having palmar erythema. Lots of these things are buzzwords that they use to describe someone in cirrhosis. Here, they didn't give you all of my classic cirrhosis features, but instead, they gave you an image. They gave you the abdominal fluid wave. That just tells you there's ascites. And jaundice is the most important clue in this one. So I diagnosed this person with cirrhosis. So cirrhosis means the liver is not working. It's a dead liver. So I think about what the liver does and the functions of the liver and what can get affected. Okay, so a lot of things will start dropping. Your albumin will drop, so protein count will drop, but also your clotting factors are going to be not made. Your factory for the clotting factors aren't working properly. So your prothrombin time and PTT, so C and E, will both be elevated in a cirrhosis because my body is not able to make clotting factors. So it's going to take longer to make thromboplastin and prothrombin. So it makes sense. Those are the times. The more likely their patients are to bleed. Bilirubin, like we talked about, the fact that there's jaundice already tells me that bilirubin's elevated. So that's already out of the picture. And then alkaline phosphatase, that kind of tells me about the function of the biliary tract and can also be associated with bone stuff, but generally biliary tract. And they tend to be elevated along with my AST and ALT in a cirrhotic patient. It depends on what phase they are, but the platelet count is going to be low in all cirrhotic patients. Why is that? Because remember when we looked at the CT scan, what organ is big? The spleen. When the liver fails, the blood backs up into the portal system and leads to what's called portal hypertension, which leads to blood pooling in the spleen. And the spleen, we know, likes to destroy things. So it destroys my platelets, and that's called splenic sequestration. So lots of high yield things I mentioned here. Maybe take a moment, read about this, look at your first aid, and really understand cirrhosis. Lots of high yield topics about the liver, and understanding that thrombocytopenia occurs as a result of cirrhosis due to the spleen is a highly tested topic all throughout the USMLEs. But good job, guys.
Yeah, nice work, everybody, and thank you, Abraham. There was I think there were probably like 3 pearls in every sentence there within that explanation. There's a lot that you can draw from it. So thinking ahead, just remember that we do post all of our question lab sessions on YouTube. So if there's something that you're thinking about or you need to review based on tonight's meeting, then you'll know where to go. So, okay, we're off to a good start. We're now ready for question number 2. And, again, we've got radiological finding here that you see. We've covered up all of the answer choices. And we are ready to get started. So obviously a little bit of a longer vignette, but I don't want you to worry about the vignette yet. I want you to think about the lead-in. So the lead-in here is, which of the following is the most likely cause of this patient's hematemesis? Okay. So now you understand what's going on with this patient, and now you're thinking about, okay, the most likely cause. So with that, let's go ahead and read the vignette. A 50-year-old male is brought to the emergency department because of hematemesis and chest pain. The patient has a history of alcohol use disorder. After recently consuming 2 pints of whiskey, the patient experienced vomiting. The vomiting was initially non-bloody, but subsequent emesis was tinged with material with a coffee ground appearance. He also developed chest pain after vomiting for the 3rd time. Physical examination is notable for tenderness to palpation over the epigastric region. There's no crepitus or guarding. Physical examination and laboratory analysis indicate no stigmata of cirrhosis. A chest X-ray is shown. So once again, which of the following is the most likely cause of this patient's hematemesis? Head on down to the question box. Let us know how many steps you think it's going to take to solve this one as I pass it to Abraham.
All right, so a little bit longer question, like Jeff mentioned. Again, you have an X-ray finding in this one, not a CT, but it's, can be helpful, may not be the most helpful. But we have to figure out what we're looking for. So let's go through, let's highlight the words, and let's go through and kind of discuss this a little bit more. Okay, again, the lead-in is the most important thing, most likely cause of the patient's hematemesis. 50-year-old male is an important thing. You always want to think about who the patient is and the demographic. Okay, hematemesis and chest pain, that's your chief complaint. You want to have an understanding of that. Alcohol use disorder, not necessarily important how, like exactly the type of alcohol or anything, but he has alcohol use disorder, that's important. And he's been vomiting, that's important. And the vomiting, the transition from the initial non-bloody to the coffee ground appearance later on is important. And from that 3rd time he was vomiting, he had chest pain. That's interesting. And then of course the physical exam gives you a big clue: tenderness, palpation in the epigastric region. So epigastric region, you want to generally think what's in that region of the human body, and you want to kind of have an idea of what that's trying to get at here. There's a few things that can jump out to you, but with the presentation, with the patient's physical exam, and with the X-ray as a support, what does this tell me? Again, there's no cirrhosis, nothing like that. There's also a reason why they said that. We'll talk about all this as well. Let's look at the options here, and let's try to figure out which would be the best option in this situation. Okay. Option E, a Mallory-Weiss tear. Option D, esophageal varices. Option C, Boerhaave syndrome. Option B, Barrett's esophagus. And option A, acute pancreatitis. Now, all very good options and all things that can cause problems and similar problems. But in this patient with alcohol use disorder and this nonstop retching and vomiting, with vomiting up coffee ground emesis and having this tenderness, really only one thing fits. So out of the options, take your time, think about it, and come up with an answer, and we can talk about this.
And the answer is answer choice E, the Mallory-Weiss tear. Great job, everybody. You guys keyed in on the details that helped you solve that one. If you didn't get that one right, though, that's okay. There's a lot of information in that, and Abraham is going to be here to help you sort it out. Abraham?
All right, great job, guys. Again, another classic situation. You have an alcoholic who is vomiting nonstop, right? So when I'm vomiting nonstop, what's going to happen, right? So I'm going to create that excess pressure, and that's going to cause issues with my esophagus. Okay. So first of all, when I think epigastric pain and alcoholism, pancreatitis jumps in my head right away, but it does not present like this, right? And acute pancreatitis will have that epigastric tenderness and pain, but they should give you something about the lipase. They should give you something else that are pointing more towards that. And they won't have esophageal ground emesis. That's not going to be chest pain or anything like that. It's going to be just epigastric pain that's present throughout the time, especially if it's acute pancreatitis. And that's the kind of the clue that they'll go for. But let's pick between the 4 esophagus issues, right? Barrett's esophagus, Boerhaave syndrome, esophageal varices, and Mallory-Weiss tears are all esophageal issues. Which of the following is a problem? Let's talk about Barrett's esophagus to begin with. So Barrett's esophagus is a precancerous change, right? These are, this is the precancerous change that happens before you get esophageal adenocarcinoma. This occurs in who? Patients who have chronic GERD. These patients have long-standing GERD, which leads to metaplasia of the lining of the esophagus, and that's what's called Barrett's esophagus. So this guy's having alcohol disorder and multiple vomiting, which leads to the sudden bleeding, not GERD over a long time leading to cancer. So that's a different story. Well, option choice D and C are also esophageal issues, and those can bleed, right? Boerhaave can have bleeding, especially after vomiting. But what would you have? What is Boerhaave syndrome? Why is it called Boerhaave? So Boerhaave is this guy's name. We don't care. It's an esophageal rupture. That's what's most important part about it. Imagine the esophagus gets a hole in it from so much vomiting and so much pressure that you will start seeing free air in the mediastinum. That's what this chest x-ray is supposed to show you. It's showing you that there's no free air floating around the chest. And what I tell you about the exam, there's no crepitus, no guard. So there's nothing indicating that there's free air subcutaneously floating around in the chest outside of the esophagus. That's what Boerhaave syndrome will present like. So the vomiting followed by chest pain is going to be the same, but they'll have crepitus when they subcutaneous crepitus or subcutaneous emphysema, they call it. On X-ray, you'll see free air floating around. In esophageal varices, remember, like what we said, there's got to they got to build that cirrhosis picture. They got to give you the history of jaundice, the history of low platelets, something like that to make you think that the person is already cirrhotic for you to think about esophageal varices bleeding. And the question says, lab analysis indicates no stigmata of cirrhosis. They're telling you this guy does not have cirrhosis. It's an acute alcohol use disorder, not something that he's been using for many, many years. And he's 50, right? So you got to think about a lot of things like that. So in this situation, a Mallory-Weiss tear is a tear that occurs in the esophagus secondary to continuous retching. It's a longitudinal laceration, so right off the mucosa, and it doesn't tear through and make a hole like Boerhaave syndrome, but it's a tear in the esophagus, and there's a significant amount of blood loss and hematosis. And this can be bloody, like bright red blood, or it can make its way down into the stomach and come back out and be coffee ground. So it can come either or. So that's important to understand, and recognizing a Mallory-Weiss tear is very important. So good job, guys. You guys did great on this one.
Yep, this is we're off to a really good start tonight, and we're about halfway home. So keep it up, everybody. Let's go ahead and take a quick stretch break. Now, as we do that, I just want to highlight a resource that can help you take your USMLE prep to the next level, which is, of course, USMLE-Rx. USMLE-Rx is your comprehensive study platform for Step 1 and Step 2. It's designed to give you everything you need and bring together all of our evidence-based tools to help you prepare with confidence. So, within USMLE-Rx, we have our RX 360 Plus, which is our all-in-one study system that includes RX bricks. We've got over 800 of these digital learning modules that help students build and strengthen their medical foundation. We've got QMAX, which has nearly 5,000 USMLE style items for both Step 1 and Step 2. Plus, we've got 2 self-assessment exams for Step 1 right now, with self-assessment exams for Step 2 coming soon. Express videos, we've got over 1,300 of these concise, high-yield videos, almost 90 hours video altogether that break down the essential concepts. So it's great for quick reviews or when you need to reinforce key topics. And we have flash facts, so over 13,000 flashcards that help you test your knowledge and build strong recall. Overall, when we talk with students, the thing that they continually stress is how much they like the way that everything integrates seamlessly. So you can move from learning to practice and practice to mastery. You can do that with ease. So again, we've got some M1s here, so you may be in the early stages of prep, or for those of you who are gearing up for game day, USMLE-Rx has the resources to support you every step of the way. So join, we've got tens of thousands of med students who trust USMLE-Rx to help them achieve their goals. And we do have a special running, which I'm going to tell you a little bit about later on this evening. Okay, stretch break is over. Let's go ahead and get into question number 3. For those of you who are question lab regulars, you may recognize that sometimes the difficulty level amps up as we go deeper into the session. So keep that in mind as we start off with question number 3, and we've got all of the answer choices covered up, and we're going to start with the lead-in. Which of the following additional laboratory findings would most likely be expected in this patient? Okay, so again, lab findings jumping out at us. So let's read the vignette. A 43-year-old man comes to the physician because of bloody diarrhea, abdominal cramping, fatigue, and severe pruritus for the past month. Medical history is significant for ulcerative colitis. Temperature is 37.1, pulse is 103, respirations are 20, and blood pressure is 105/80. Physical examination reveals scleral icterus and diffuse excoriations. So the question again, which of the following additional laboratory findings would most likely be expected in this patient? With the information that's been presented, how many steps do you think it's going to take? Is this a 1-step, 2-step, 3-step question? Let us know down in the question box as I pass it to Abraham.
All right, thank you, Jeff. So again, we have not a huge question, and this one doesn't have any image associated with it, but it expects you to kind of take a few steps in getting to the answer. Okay, so let's highlight some of the keywords here. Let's work our way through the question one time. So again, it's not asking about diagnosis, about additional lab finding expected in this patient. Always make sure you know your lead-in before you jump into the question. 43-year-old man, bloody diarrhea and abdominal cramping, right? You always want to think about what are some unique stuff, right? Fatigue, everyone's got some fatigue. So bloody diarrhea, abdominal cramping, severe pruritus, and it's been pumping for 1 month. That's interesting. And they tell you the diagnosis, ulcerative colitis. So he has a history of ulcerative colitis, but it comes in with maybe some additional features, maybe just all ulcerative colitis. No fever, slight elevation in the pulse, respiration is okay, blood pressure is okay, and has scleral icterus and diffuse excoriations. So yellow eyes and scratch marks everywhere. What additional lab finding would you expect in this patient? So let's look at the options. Let's try to start thinking caps on here and try to figure out what's going on and why he's having this. So again, start with option E and make your way up. So option E, positive C-ANCA. Option D, positive anti-mitochondrial antibody. Option C, elevated carbohydrate antigen 19-9, which is CA19-9. Option B, elevated alkaline phosphatase. And option A, decreased ceruloplasmin. Each of these correlate with a different disease or a different condition, and they're all titled in its own aspect. But in this situation, a person with ulcerative colitis presenting like this, what would I expect in this patient and why? So take a second, digest all the information they give you, and let's tackle this question.
Okay, we're going to launch the poll. Okay, so we've got, unlike our first 2 questions, it's kind of a 2-horse race here between elevated alkaline phosphatase and positive C-ANCA. Did get some votes there for answer choice D and a few for A and C, but looks like a lot of you were thinking hard about B and E. So interesting. Let's go ahead and hide the results. and let's share the answer. And the answer is answer choice B, elevated alkaline phosphatase. So good work, everybody. Again, tougher question. If you didn't get it right, it's okay. This is the time to get it wrong. So Abraham's going to be here to help clarify for you. Abraham?
All right. Well, great job, guys. Again, this is a tricky one, so don't feel bad. And option choice E is a tempting option, and I see why a lot of you guys picked it. It is kind of a trap that they laid out here, and I'm going to explain why that's not the right answer and why the actual answer is B. So first of all, let's go back to the question. Let's tackle the question one more time. So we have this guy who has ulcerative colitis, but he's been having scleral icterus, which is essentially them telling us jaundice, right? Or their bilirubin's elevated, and there's itchiness all over their body, diffuse excoriations and pruritus. So ulcerative colitis by itself doesn't cause jaundice and excoriations and pruritus. There's something that's associated with ulcerative colitis that causes that. You can't even tell me what that association is. If you guys want to drop it in the question bank here, box here. What condition are they talking about that connects ulcerative colitis with the patient's current presentation? Take a second. It is PSC, primary sclerosing cholangitis. That is what's going on with this patient and why the person is presenting how they're doing. So that's a diagnosis they expect you to get, which is based on the presentation they're giving you. Using that information, we can get to the answer. So let's look at the options. Let's rule out some of the incorrect options and let's see why B is actually the correct answer. So let's start with option E, like the one that everybody picked. Why is option E wrong? Well, C-ANCA is actually not seen in either ulcerative colitis or in PSC, primary sclerosing cholangitis. It is seen in granulomatosis with polyangiitis. That's the old name for that was Wegener's granulomatosis. But the new name, what they use is GPA, granulomatosis with polyangiitis. That's C-ANCA. And then the reason why a lot of you may be confused is ulcerative colitis has P-ANCA positivity. P as in Peter, not C. So P-ANCA positivity can be seen in ulcerative colitis. So this is different than C-ANCA. That's why option choice E is incorrect. Option choice D, anti-mitochondrial antibodies. So that is seen in primary biliary cholangitis. That's the track. Okay, so that's the other primary bile issue. So it's not primary sclerosing cholangitis. It's primary biliary cholangitis, which is an autoimmune disease and not associated with ulcerative colitis. Option choice C, elevated CA19-9. That kind of points towards what? Pancreatic cancer, right? CA19-9 is one of our tumor markers we use to track pancreatic cancer. And that's an association that you should know, but not associated with primary sclerosing cholangitis or ulcerative colitis. And decreased ceruloplasmin, that's one of the classic questions that I love to ask, and that's definitely not got to do with this one. It's Wilson's disease, right? It's that whole Kaiser-Fleischer rings and the classic cirrhosis with corneal deposits and things like that. That's the classic story that they give you for Wilson's disease. Buildup of copper leads to reduced ceruloplasmin. So why do you have elevated alkaline phosphatase? Well, primary sclerosing cholangitis is sclerosis, inflammation and scarring of the biliary tract. And alkaline phosphatase always goes up when the biliary tract is messed with. So you have to remember, if the alkaline phosphatase is elevated more than AST and ALT is the primary thing, then you think, oh, it's more of a biliary cholestatic pattern. PSC is a cholestatic disease, which is linked with ulcerative colitis and even Crohn's, mainly with ulcerative colitis, but also Crohn's. And it leads to that beading chain of links appearance kind of thing that they often describe on ERCP, and that's very high yield. So good job, guys, getting this one. Tough one for sure, but definitely important to understand that PSC is associated with ulcerative colitis, and it presents like this with the jaundice and with itching, and is associated with an elevated alkaline phosphatase.
Well done, everybody. Again, yeah, a tougher question, and thank you for the deep dive there, Abraham. Especially for those of you who are just starting your step prep. You know, one of the great things here, and especially the way that Abraham describes it, is you know, you can see how this particular scenario could be adjusted so that, you know, really any of these answer choices could be correct, and it's a good way to you know, to study in prep, especially for areas in which maybe GI isn't your strongest area, or maybe it's something that, maybe you're even in the midst of this block right now. So it's important to go through those incorrect distractors, and now it's one thing to figure out, oh, why did I get this one wrong? That's helpful from a tactical standpoint, but you should really have a good understanding of why the correct answer is right and all of the incorrect answers are wrong, and then think about it in terms of, well, what would it take for one of those other options to be right. It's a good exercise to help kind of strengthen your part of your clinical reasoning abilities. So anyway, thank you, Abraham. This is always my favorite part of our question dissections. So with that, we've reached the final question of the night. Question number 4. You guys have done a really nice job tonight, and great engagement, good questions there in the question box. So let's go ahead and open it up here. So the answer choices have been covered up, and we're going to start, as usual, with the lead-in. An increase in which of the following hormones is most likely responsible for the patient's presentation? Okay, so that kind of keys us in. We're going to be thinking about hormones as we wade into the vignette. A 43-year-old man comes to the physician's office because of intermittent facial flushing and watery diarrhea for the past 6 weeks. He also reports episodes of lethargy and weakness in his lower extremities. He has a family history of numerous tumors and kidney stones. A CT scan reveals a mass in the pancreas. Laboratory tests show a serum potassium of 3.1, blood glucose of 110, and an elevated gastric pH. So again, the question, an increase in which of the following hormones is most likely responsible for the patient's presentation? I see some of you have been letting us know the number of steps, but it would be good. Yeah, how many steps do you think it'll take to get to this one? 1, 2, 3? Let us know in the question box as I pass it over to Abraham.
All right, so we have a different style of question here. It's talking about hormones a little bit, and it's kind of associating GI with my endocrine system, and kind of want to think a little bit more broad, multi-system questions. And STEP loves these kind of questions, so we want to be aware of this. They give us some lab values. So let's go through, highlight some of the keywords here, and let's figure out what's going on. Again, increase in which of the following hormones is responsible. So not asking about diagnosis, just saying, hey, what's going on? So obviously you have to get a diagnosis first to get to the answer, but that's what the question is asking. So you have a 43-year-old man, intermittent facial flushing, watery diarrhea past 6 weeks. So that should be ringing some bells. There's a few things that can cause similar ideas of the flushing with diarrhea. Lethargy, weakness, okay. Family history of numerous tumors and kidney stones. Interesting. So why would they randomly throw that in there? Maybe that's relevant. A CT scan showed a mass in the pancreas. Okay, so there's some kind of pancreatic mass going on. And they give us a lab value. So potassium is low at 3.1. Blood glucose, 110. Sure, it's a little bit on the higher, but it's okay. And elevated gastric pH. That's unique. So high gastric pH, a low potassium, family history of tumors, a pancreatic mass, and presenting with flushing and watery diarrhea for the past 6 weeks. So those are the big clues they're giving you. You want to connect the dots, find a unifying diagnosis that's going to connect all of these features together into one thing, and then think about what hormone is elevated and would be responsible for this presentation. So think about that as we reveal the options. All right, so we have 5 options, just like usual. I'm going to start from E and make my way to A. Option E, vasoactive intestinal peptide, polypeptide. Option choice D, serotonin. Option choice C, insulin. Option choice B, gastrin. Option choice A, catecholamines. Okay, so all of these are important, and they're all kind of associated with different things. And some of them have features that the patient has, but all of the features will connect only with one of these options. So that's the classic trick of this question here. So take your time, think about what the question's given you. Think about the flushing, the watery diarrhea for 6 weeks. Think about the family history of tumors. Think about the pancreatic mass, the low potassium, the high gastric pH, and then what hormone would be associated with them. So take your time as the poll pops up.
Okay, we've launched the poll. Go ahead and take a shot. And I saw a question in the question box that, again, sometimes we will do question lab. We've done this a couple hundred, almost, 170 times now, 180. So sometimes we assume some knowledge, but Abraham, I thought maybe it'd be good for you to just kind of explain what we talk about when we talk about a one-step versus a two-step or three-step question.
Sure. Yeah, that's a great question. I think definitely important to understand what we talk about when we talk about steps in questioning. We always want to have an idea of getting into the test writer's mind. We want to think about what kind of question they're asking me. Is it a question where is it a one step where I'm just responsible for coming up with the diagnosis based on the information? It's a one step. A two step, is it asking me for the treatment? So I'm thinking about diagnosis and what's the treatment? Or is it a three step, or is it asking me to figure out the diagnosis, figure out the treatment, and figure out the mechanism of action of the treatment? So these are the ways you want to understand what complexity of the question is ranging from, and how the test writer wants you to answer this question. So that is all kind of things that you want to think about as you're reading the question, because it does help you organize your thought process when you do get to the part where you do have to pick an answer.
Excellent, thank you. Let's go ahead and I'm going to get ready to close the poll here. Got almost 3/4 of you who have cast your vote. Okay, I'm going to close it and let's share the results. And for this one, over half of you went with answer choice E, vasoactive intestinal polypeptide, and then kind of a battle for second place amongst serotonin, gastrin, and catecholamines. So interesting spread. Let's go ahead and hide the results and reveal the answer. And the answer is answer choice E. So nice work, everybody. That sometimes the fourth question is amongst the toughest, but you really rose to the occasion. If you didn't get that one, that's okay. Abraham's going to walk you through it, but I want everyone to be tuning in here because again, let's think about all of these different answer choices and the things that actually make them wrong and could make them right in a different scenario. Abraham?
All right, thank you, Jeff. So yes, good job, guys. Again, this question can be challenging to a lot of people, but you guys blew through it. Awesome to see that. So let's think about what really is going on here and why is VIP, or vasoactive intestinal polypeptide, the answer, right? So this patient has a VIP-oma. It's an endocrine tumor which rises in the pancreas and has a classic triad of watery diarrhea, an elevated gastric pH, and hypokalemia, which is exactly what the patient has. So that's kind of the clue. If you were able to recognize that and connect that to a VIP-oma, you already got to the answer. So the hypokalemia, elevated gastric pH, and this diarrhea with the flushing is the classic symptoms that you see in a VIP-oma. Now, what are the other clues that they gave me in this, and why are the other options wrong? So the other big clue that they gave me, why are they talking about family history of tumors and kidney stones? Well, what they're really trying to get at is that VIP-omas are pretty rare tumors to begin with, and they have a big association with the multiple endocrine neoplasia type 1. So MEN1, right? We learned about the MEN1, MEN2A, MEN2B. Those are all high yield. And in this setting, the MEN1 diseases are important. MEN1 diseases are the ones that are the pituitary, pancreatic, and parathyroid, the 3 Ps, right? Remember, P for primary, P for 1. So MEN1, pituitary, pancreatic, and parathyroid. So tumors of all 3. That's what they're trying to really get at with the family history of numerous tumors, and the kidney stones, if you have hyperparathyroidism, hypercalcemia, stones. That's the kind of connection. It's a little bit of a stretch for you to kind of think extra. You don't really need that if you know the triad right away, but that's a clue that they're giving you. So let's look at the other options and tell me why those are not correct. So catecholamines, right? So catecholamine elevation can be seen in catecholamine secreting tumors of the adrenal medulla, such as the pheochromocytoma. Classic, they get symptomatic or episodic headaches, hypertension, and sweating and like adrenergic symptoms. They get just a super sudden burst in epinephrine and norepinephrine, and that's a pheochromocytoma. What about gastrin, option B? Well, if I have a gastrin elevation, do I expect my gastric acid to be elevated? Yes, right? So my pH should be low in that situation. A gastrinoma, also known as Zollinger-Ellison syndrome, is a tumor also of the pancreas, but instead of secreting VIP, it's secreting gastrin, which then makes your stomach secrete more gastric acid, which leads to gastritis, ulcers that don't go away, and you see a decreased gastric pH, not elevated. Insulin, right? Insulin is also secreted from the pancreas, so it's another tumor of the pancreas. So these are insulinomas. These are very rare benign tumors that can be seen. And if you think about it, if I secrete a bunch of insulin, it's not going to really mess with my gastric pH, but it is going to drop my sugars. It's going to cause hypoglycemia associated with confusion, tachycardia, things like that, right? So you want to know, oh, that's an insulinoma, my glucose is going to drop. And serotonin is option D. And that serotonin secreting tumors are called carcinoid tumors. And those typically arise anywhere from the GI tract, and they can often metastasize to the liver. And these have the diarrhea flushing like you see here, but you would not have that elevated gastric pH, which is classic for a VIP tumor, which causes that achlorhydria, which is that classic presentation that's getting here. So good job, guys. Definitely a tricky question, but you guys got this one right. And you know, definitely take all the options and learn from each one of them, not just the right answer.
Yeah, here. Again, congratulations, everybody. Just for showing up. You know, you're putting in the work and putting in the time, especially for those of you, you know, staying up late. I did put, you know, for those of you who do have access to QMAX, I put a link to the test for tonight in the chat. So you can go ahead and take a hard look at that. You can look at, again, all of the various explanations and all of the connected bricks and videos and flash facts for those of you with RX 360 Plus. So go ahead, you can screenshot that or just use the link.